Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. Today, I want to talk about the fundamentals of IV therapy. I don't remember being taught the principles and complexities of IV therapy in nursing school. All I remember was being taught how to spike a bag and program the pump. But there is so much more to IV therapy that I had to figure out for myself over the course of many years. In this video, I will teach you some of the really important things they probably never taught you in nursing school. Whether you're a new or experienced nurse, stick around to the very end because I'm sure you will gain value from the things I have to teach. After all, many of the things I will talk about come from real-world mistakes made by experienced nurses. The main goal of this video is to help you learn a whole smorgasbord of things related to IV therapy, from general principles to complications. Intravenous or IV therapy is a medical treatment in which a needle and thin plastic tube is inserted into a person's vein so that fluids or medications can be given directly into the bloodstream. The advantage of IV administration over oral administration is that oral administration takes much longer to take effect. IV-based treatments start working within seconds to minutes. A large part of nursing practice involves IV therapy, so nurses need to be incredibly knowledgeable about this subject. The mechanics and procedures of IV therapy are actually quite simple. I'm willing to bet we can train a monkey to insert an IV needle into a vein and connect it to a bag of fluids. And I'm certain a 10-year-old child can attach a syringe to an IV line and push a medication. Anyone can be trained to do this. But only nurses and a few other medical professionals are legally permitted to do so. The reason you need a professional license to do this is because it's the nuances that make IV therapy complex and dangerous. It's very easy to administer IV therapy, and it's just as easy to inadvertently kill a person from carelessness. Always, always, always be mindful of the entire clinical situation and use critical thinking when administering IV therapy. Safety is always a top priority in patient care, and if you are complacent and are not diligent in practicing good habits, you will harm your patient. Up front, here are a few safety practices that you should adhere to. Always critically think before you act. Verify fluid and medication compatibilities. Never forget about line dead space, which I will talk about more in detail later. Keep your IV lines organized and neat. Scrub the hub and maintain sterility at all times. Give nearly all IV push medications slowly over 1 to 2 minutes. With very few case-by-case exceptions, I always push any medication over at least 1 minute. It drives me nuts when a nurse thinks 10 seconds is a slow push. I personally consider it bad practice to give routine IV push meds in less than a minute. So yeah, I am judging some of you. There are many different types of vascular access devices. They can broadly be divided into peripheral access and central access. Peripheral access devices are short catheters typically inserted in the veins of the upper extremities, but occasionally in the lower extremities. Central venous catheters are inserted into the veins of the neck, chest, arm, or groin, and they usually extend into the vena cava close to the heart. They are preferred when administering medications that are irritants or vesicants which can damage the smaller peripheral veins. The peripheral IV cannula, or PIV, is by far the most common type of vascular access device. Nearly everyone who shows up to the hospital gets one of these. They come in various sizes and lengths. The size or thickness of a PIV ranges from 14 gauge up to 26 gauge. The smaller the number, the larger the diameter of the cannula. Smaller number, bigger IV. The sizes are universally colored so you can quickly identify the size, even if you're not the one who inserted it. Oftentimes, it's the nurse who decides on the size of the PIV to insert. Be sure to choose a gauge that is appropriate to the clinical situation. A midline is another form of peripheral IV access. The midline is much longer than a PIV, but does not reach the central circulation. Because they sit much deeper in the vein, they are less likely to get dislodged and often last much longer than a standard PIV. Moving on to central lines, there are a bunch. I'm not going to review them individually, but they include the triple lumen CVC, PICC line, introducer sheath, Swan-Ganz catheter, portacath, dialysis catheters, and various other tunneled catheters. Most have different functions in addition to just delivering fluids or medications. For example, some of them can be used for hemodynamic monitoring. Central lines can stay in for prolonged periods of time. Depending on the type, they may stay in for weeks or even years. But they do require meticulous care to prevent a central line-associated bloodstream infection. IV fluids are given to patients who are dehydrated and as a treatment for patients with low blood pressure. Standard IV solutions, also known as crystalloids, may contain various substances like dextrose, bicarbonate, lactate, or electrolytes like sodium, potassium, chloride, magnesium, or calcium. When it comes to IV fluid selection, it is actually very nuanced, and I could probably have an entire video on IV solutions alone. The key point I want to convey here is that IV fluids are broadly categorized as either maintenance fluid or resuscitation fluid. When using crystalloids for resuscitation, be sure to only use isotonic solutions. This means the IV fluid has a similar concentration of solutes as human blood. You only have 3 choices for fluid resuscitation: normal saline, lactated ringers, or plasma-lyte. All other fluids are maintenance fluids and are used for gentle rehydration, not resuscitation. Dead space is an important topic that was certainly never taught to me. Infusion dead space is the internal volume of a catheter and tubing through which a fluid must pass through before reaching the patient's blood. Careful thought must be given at all times when starting slow infusions, pushing small volume boluses, or connecting lines in a series. Some continuous drips, like vasopressors, may start as low as 1 ml per hour. If that IV line is connected to a peripheral extension tube or a central line, it could take 30 or more minutes for the medication to travel through the plastic before ever reaching the circulation. Patients can't wait 30 minutes for vasopressors when their BP is already 40 over dead. It may be necessary to start these infusions at a high rate, then drop it back down once all that dead space has been overcome. Dead space is one of the reasons we flush a line after giving meds, to push it all in so none of it remains in the catheter. Beware, conversely, there are situations where you never want to flush a line. If you flush a central line with vasopressors running in it, not only have you given the patient a small bolus, now you have reset the dead space, and it's going to take time to get the meds through to the circulation again. Clearly, dead space can be a significant problem. There are a few ways to compensate for dead space. Always attach a drip or syringe to the port closest to the patient. This minimizes, but does not eliminate, the amount of dead space the medication has to pass through. You can also Y-site a drip. Using a PCA, for example, you can connect it to a faster flowing infusion so that the tiny volume boluses can catch a ride into the circulation. Lastly, dead space can be overcome by diluting medications in a larger volume of diluent. Larger volumes will have proportionally less residual left in the tubing, but still will require a flush to push the remaining medication through. Most patients in the ICU are on many different drips. It's the hallmark of critical care. But all too often, I have witnessed nurses who do not fully grasp pharmacokinetics. We need to utilize the modality that is appropriate for a given situation, especially regarding sedation and analgesia. Say a patient is on a sedative drip, but suddenly has breakthrough agitation and is thrashing in bed. It's not enough to just up-titrate the drip rate. Depending on the medication, drip changes may take effect after several minutes or even up to an hour or longer. A patient that needs immediate de-escalation will require a bolus injection. Remember, if you have a continuous symptom, you need a continuous drip. If you have intermittent symptoms, you need intermittent boluses. If a patient is intubated for days with continuous discomfort from the ET tube, bolus injections would be a horrible sedation strategy. The patient would keep waking up every few hours between doses rather than staying consistently sedated and comfortable with the drip. Drips can also be great when you want to be a little more cautious with your treatment. If a patient is hypertensive, it's safer to start a drip and gradually bring down the blood pressure. A bolus injection has a greater potential to precipitously drop the blood pressure, and you can't take it back once you give it. So remember to analyze any situation and decide if a continuous drip or intermittent bolus is the better choice. A secondary infusion, or IV piggyback, is typically a small volume infusion intended to run over a short period of time. It permits a more complete administration of a medication than if run as a primary infusion. Again, this goes back to the problem of dead space. If you had set up a 50 ml piggyback as a primary infusion, you would probably end up with about 40% of the dose still in the tubing and not in the patient. Depending on the type of IV pump you have, the IV piggyback must be physically higher than the primary solution. Don't ask me how the pump only pulls from the higher bag. I only got a C in high school physics. It just does. Extreme caution must be exercised when administering high-risk, rate-sensitive medications like potassium. Let's say the potassium is running as a piggyback at 25 mL per hour and the pump thinks the infusion is complete. It will automatically switch back to the primary rate that maybe was running at 125 mL per hour. You very well might be infusing the remaining amount of potassium in the line at 5 times the recommended rate. You may want to consider lowering the primary infusion rate to a TKO rate until you are certain all the potassium has been infused in. Sometimes you have multiple piggyback medications due at the same time, but limited IV access. Prioritize the administration by importance, frequency, or duration of infusion. For example, it's much more important to get antibiotics in on time versus giving something like Pepcid. When two meds are of equal importance, prioritize the one with a higher frequency. A med that is due every 6 hours needs to stay on time more than a med that's only given once a day. The last, and probably most important point on piggybacks is that the primary infusion is on hold until the piggyback is completed. There was a nurse who piggybacked a 4-hour infusion onto a resuscitation fluid running at 250 mL per hour. While the piggyback was slowly running, the patient wasn't getting a whole liter of fluid over those 4 hours, and their BP and urine output started to drop. The nurse did not critically think about the situation. Rather than piggybacking the med, they should have set it up to run in tandem with the primary infusion so the patient would receive both simultaneously. Nurses routinely diluting IV push medications is a controversial subject. Unless there are explicit instructions by the manufacturer to dilute the particular med, several national guidelines recommend against dilution for some very good reasons. But as a baby nurse, it was ingrained in me to dilute my medications, especially any narcotics. Diluting medications allows for the nurse to have better control over the rate of administration, reduces issues of line dead space, and increases patient satisfaction by decreasing pain or discomfort from irritating drugs. It is very difficult to push 1 ml of medication over 1 or 2 minutes. It's much easier to push 10 mLs slowly and evenly. Diluting the medication does not affect the total dose given, just the rate in which it is pushed. Sometimes patients complain when I dilute their Dilaudid, but I assure them they are still receiving the full dose as prescribed. Because it goes against national guidelines, I cannot openly endorse the practice of diluting medications. However, I do strongly believe it is an important safety measure if done properly. The opposite of diluting medications is concentrating them. Concentrating a drip increases the dose per volume. Sometimes patients in the ICU are on a ton of drips to keep them alive, and that might equal a few hundred mLs per hour. Sometimes this is not a problem, but many critical patients have heart failure or kidney failure, and we want to reduce the total amount of fluid we give them. Concentrating a drip also allows the IV bag to last longer, which is great when the nurse has a million other things to do. Just remember, when concentrating vasopressors, it must be infused through a central line. Since the medication is more concentrated, it can cause even worse damage if it extravasates from a peripheral IV. The most important things to remember when having pharmacy change the concentration of any drip is to use new IV tubing to prime the bag and reprogram the IV pump. Failure to do both will result in significant medication dosing errors and a fun incident report. This is the part where I get really mean. Infection prevention is one of the things I am passionate about. I have zero tolerance for nurses who have poor infection prevention practices. Sepsis is one of the world's biggest killers, and yet it is largely preventable. I'm not going to preach about hand hygiene in this video. You already know how important that is. But I am going to teach you some of the other things that you should always or should never do in regards to IV therapy. Always scrub the hub each and every time you access an IV port. There is no excuse for this. Every nurse should be carrying alcohol pads on them, and they should be vigorously cleaning any port they intend to use. I would contend that not scrubbing the hub every time is malpractice, since you are knowingly and willfully exposing your patient to microbial contamination. Always leave IV bags and flushes capped right until you are about to use them. I have seen nurses pull the plug out of an IV bag and leave it exposed for some time before spiking it. It can easily get contaminated in the meantime. I have also seen nurses toss uncapped flushes onto the bed in preparation for using them. Those uncapped flushes are immediately contaminated and should never be used. Once a sterile item is uncapped, you should ideally be using it within a few seconds, certainly not several minutes. Always change the IV tubing according to your hospital's policy. Most tubing is changed every 4 to 7 days, but certain infusions like propofol or TPN require changes much more frequently due to their ability to easily grow microorganisms. Never loop the end of the IV tubing into the injection port. You should always use a sterile cap to protect the tubing when it is not connected to the patient. And there should never be a piggyback hanging on the pole with the tubing flapping in the wind without a cap. Never use a needle to vent the bottle of albumin or any other viscous solution. That needle converts a closed sterile system into an open system where bacteria now have free, easy access to the solution. You might think I'm being a little excessive, but I guarantee those clean gloves have already touched something else before touching that needle hub. And as a reminder, there are also microbes floating around in the air as you breathe near that IV. Never use a syringe that has exceeded one pull-push cycle. What I mean is that once the plunger has been pulled back and then fully depressed, that syringe is now trash. This contradicts what they teach in nursing school, where they tell you to pull in a bunch of air, then inject it into a vial, then pull back the medication, then give it to the patient. That repeated in and out motion of the plunger contaminates the inner barrel of the syringe. In my experience, very few vials require the injection of air to extract the medication. Just abandon this poor practice. Never use any supplies that have questionable sterility. If you think you accidentally touched your glove with the spike, throw it away. If an unwrapped flush is randomly lying on the counter, throw it away. If tubing isn't marked with the date and time, throw it away. If that was your loved one in the bed, I know you wouldn't be taking any chances. As a nurse, a part of your job is monitoring for treatment complications. Here's a list of IV therapy complications you should be monitoring for, and report them to the physician as appropriate. IV sites that are red, warm, and maybe have purulent drainage might be infected, and the IV should be removed. Phlebitis is an irritation and inflammation along a vein and can eventually lead to vein scarring. When a solution or medication leaks out of the vein into the surrounding tissue, this is known as infiltration or extravasation. We call it infiltration when it's a benign fluid, or extravasation when it's a vesicant that can cause tissue damage. Nerve injuries can potentially occur when inserting a peripheral IV. If there is intense pain out of proportion to the procedure, just abort it and try at a different site. Air embolism is a potentially fatal complication if you are not careful to eliminate all the air bubbles within IV lines. Central lines are great, but they are subject to various complications like occlusions, thromboses, and malpositioning. If you have a patient with a brand new central line and also brand new dysrhythmias, get a chest x-ray to make sure the catheter is not too far into the heart. I reviewed a bunch of different principles related to IV therapy. Here's a summary of the most important key points. Always critically think before administering anything IV. You need to understand what you are doing, why you are doing it, how to do it correctly, and if there is any reason not to do it. The only fluids used for resuscitation are normal saline, lactated ringers, or plasmolyte. Be mindful of dead space and compensate accordingly. Know when to adjust a continuous drip or give a bolus dose. Remember, the primary infusion is on hold while a piggyback is running. Consider diluting IV push medications and administer them slowly. Use new tubing and reprogram the IV pump when changing the concentration of a drip. Practice strict infection prevention measures at all times. And routinely monitor IV sites for complications. Thanks for sticking around to the end. If you learned something new, let me know in the comments below. Or if you're an expert and already knew everything I discussed, let me know that too. If you haven't already done so, please like and share this video and consider subscribing to my channel so I can reach more nurses like yourself. Thanks again, and I hope you will join me in my next video.